biopsy procedure. We are honored to have with us Dr. James Anthony Bhagat, sir, Professor, Adiparashakti Dental College and Hospital, who will be performing the surgical procedure for us in the operating room. And to moderate us and encourage this session, we have Dr. Nachiappan, sir, Head of the Department of Oral and Maxillofacial Surgery, Satyabama Dental College and Hospital. We welcome you, sir. Let's welcome with a round of applause.
Hello, James. Can you hear me? Good morning, everyone. Yeah. First of all, I'd like to thank the management of Tagore Dental College, as well as HOD Dr. Riyaz sir for giving me this opportunity. Now we are going to see the today's case is the biopsy, and it is a cyst in the maxillary anterior region on the left side. Okay. Next slide, please. Yeah. Patient name Mrs. Dhanlashmi, 34 years old. She's a homemaker, and she came with a complaint of pain and swelling in the left upper front tooth region for the past 2 weeks. And from the history of present illness, patient gives a history of trauma to her upper front teeth 2 years back, following which she has developed gradually change in the color of the tooth. Okay. And she gives a history of pain, which is gradual in onset, dull, constant, and nocturnal pain, and increases in severity associated with slow growing, gradually increasing size of swelling. And there's no history of sinus opening or pus discharge. What is your message from here? Should be interactive, not a one-way communication. I like to be interactive. Yes, trauma has happened. Yes, 2 years back, and there is a change in discoloration. So, what will be your initial diagnosis? Will be there. Yes. Anyone? There's a trauma. There's a discoloration of the tooth. So, non-vital tooth. Yes, it will be a non-vital tooth. Yeah. There's no past medical history or past surgical history, and this is a patient's first dental visit here. And coming to general examination, patient is conscious, oriented, and verbal to command. She is moderately built, airway is clear, no breathing difficulty, or vital signs are stable. And coming to the main extraoral examination, we have an inspection and palpation. Inspection, you can see a diffuse swelling present over the left nasolabial region. You can appreciate that on the left, the size of 2 into 2 centimeters. Okay, dome shaped, smooth surface with no pus discharge. On palpation, there is a the swelling is very firm, and on touch, it is warm, and tenderness is positive on the left side. And this is the extraoral profile of the patient on the right lateral view, straight view on the left lateral view. You can appreciate, you can appreciate in the bird's view, there's a swelling there. You can appreciate there. Yes, on the nasal labial fold. Yes. On the worm's view also, you can appreciate the swelling, extraoral swelling we can present there. Intraoral examination has tenderness on 2-1, 2-2, 2-3, and 2-4, and non-vitality discoloration is seen in 2-1, 2-2, and 2-3 region. Patient has a tongue thrusting habit. Okay, so there is a spacing in the or a maxillary proclination of your anterior teeth, and that's a generalized recession also seen there. This is the occlusion of the patient on the right side. On the left side, you can see a proper molar relationship. Only in the frontal region, due to contrasting habit, you can see there is a proclination of your anterior teeth with discolored 2-1 with spacing and gingival recession. You can appreciate it, yes? Yeah? Okay. From this, what are the diagnosis will be? There's no sinus opening, only there's a swelling on the upper front tooth region. Yes? Okay, I'll go with this. Can you appreciate anything here in this slide? In this one? Yes. From the anterior region, you can see this. There's erosion and expansion of the both labial and palatal cortex. Okay. Which is of in the anterior region. Okay. And what is this? What is that? What is that? Radiolucency in the central region. What is that? Any foramen? Yes. Okay. So this is an axial view, and this is from the sagittal view. You can see the swelling, which is gradually increases. Okay. You can appreciate here. You can appreciate here. Okay. This is the labial, and this is the palatal cortex. Okay. The palatal cortex slowly started erosion. Okay. Bony erosions are there, and this is the OPG showing a radiolucency around 2122 and 23 region. Yes, you can appreciate that. Hopefully, from this, what will be your diagnosis? You are seeing the X-ray. You have a clinical symptoms and everything. And what will be your diagnosis from here? Periapical. Okay. What will be your differential diagnosis? Yes. Nasolabial. Okay. Other things you think of most common in the anterior region? Any tumors you can tell, which is more common in the anterior maxilla? AOT, adenomatoorogenic tumor. Excellent. Yes, AOT will also present with the same thing, with swelling, and will have a same radiolucency and with the sclerotic border around it. Okay. So differential diagnosis is a periapical cyst or non-vital with periapical pathology, can be a granuloma, which is granuloma will be very small, not so big. And watergenic keratocyst, which is always associated with the impacted teeth. AOT, you can think of, this is very common, and periodontal abscess. How would you differentiate tumor from cyst? Yeah. Okay. Then, if there's a cyst, you do something before doing any procedure. Aspirate. Yes. What do you get? If it is infected cyst or periodontal cyst, what do you get? Yes. Not cheesy. It is infected cyst already. I told you. So it will be a colorless, dark red color will be coming. Okay. If you aspirate. If it is a tumor, there's nothing will come. Okay. It's a solid mass. So nothing will come. So you need to differentiate before doing a biopsy. You need to aspirate and see whether it is a tumor or it is a cystic. Okay. And final diagnosis is a periapical cyst in 2122 and 23. And proposed treatment plan is they have done an endodontic treatment for 2122 and 23 of which is they have done obturation 5 beyond the apex, so that they do apicectomy once you remove the cystic lining. Okay. And surgical management cystic nucleation followed by apicectomy of the affected teeth. Yeah. Yes. Any doubts here? Okay, we go on to surgical now. Good morning, James.
So good morning, sir. Good morning.
Yeah.
So we'll start with the procedure.
Yes.
As discussed, we are planning for a periapical cyst removal in
Yeah.
relation to 2-1 to 2-3.
Okay.
Already endodontic management is done.
Okay.
Planning to give infraorbital nerve block and associated infiltrations around the
Okay.
teeth. We'll plan for a lateral flap, sir.
Okay. What?
Since we've seen the CBCT, some amount of nasal mucosa seems to be involved.
Okay.
So in that case, we thought once the intraorbital nerve block is given, some
Okay.
small infiltration into the nose also, sir, for the
Okay.
nasal mucosa to get anesthetized. Yes, sir.
Yeah. What are different types of incisions or flaps we can go thinking of this cyst?
So For periapical cysts, most commonly we can use a quadrilateral flap.
Yes.
I'm
asking students.
Yes, sir. Yes, sir. Yes, sir. Yeah.
It's not Viva for you, it's for students.
Yes. Yes.
Yeah. Anyone, any students? All are different type of flaps, you know. We have a from basic envelope flap, trapezoidal flap, triangular flap, and semilunar flap. Which is the most easily done or which have a better visibility access. Yes, it is a four corner flap where we do a clavicular incision around the tooth and we give a two relaxing incisions on either side so that we have a beautiful flap and the base should be wide because why? The base of the flap should be wide because to have a proper blood supply to the area. Yes. Yeah. Sir has already given an infraorbital nerve block on the left side and multiple infiltrations around the tooth. Yeah. Why sir has given a nasal infiltration? Why? The cystic involvement is not, it is going up to the piriform aperture. So once you touch the piriform aperture, patient will have a severe pain if you don't give a infiltration in the nasal region. Yeah. Yes, he's giving. Okay. What syringe is using? Insulin syringe. Yes. Always try to use an insulin syringe. It's very thin. It is very painless. Okay. Compared to your 2 ml syringe, which is very painful.
So, sir, am I audible?
Yeah.
Yeah, yes, sir. Since nasal mucosal injection is slightly painful,
Okay.
what I have given is infraorbital nerve block. I have given priorly.
Yeah.
So some amount of
Relief
oxygen
from
would have come. And then I have also applied some vocal jelly, sir.
Okay.
LA jelly,
Okay.
so that pain is minimal.
Pain is minimal before giving
Yes.
injection. Okay. Yeah. For the nasopalatine nerve block or greater palatine nerve block, you can try insulin syringe. It will work wonderful. Patient will have less pain, very less pain compared to a 2 ml syringe, where patient will jump in the dental chair and even giving a 0.1 ml is very difficult when you give a 2 ml syringe.
Yes. So today we're trying the pre-injection technique for the nasopalatal, sir.
Okay.
So since infraorbital is given,
Yes.
there is a huge diastema between the two teeth.
Yeah.
I'm trying to go towards the palate.
Palate. Okay.
Second injection.
Maxillary anterior and mandibular anterior, you can try insulin syringe than your 2 ml. Okay. It's not for the nerve block, it's just for the infiltration. Okay. Nerve block, you use on 2 ml or a enolog syringe. Okay. Sir is giving a nasopalatine nerve block. Okay. Which is the most painful nerve block? Nasopalatine. Yes. After trauma, what happens? How cyst forms? Is a trauma 2 years back and there is a discolored 2-1. And how does a cyst forms? Yes. Yes, very good. Remnants of epithelial cell rest of malas will get proliferated from the apex and it goes on, and It slowly started. It is a sac filled with fluid or debris,
Cell, right?
and it is a slow growing where patient doesn't appreciate much. It will go very slowly. It is a chronic lesion, and once it is gone beyond 1 centimeter or more than 1 centimeter, or patient is feeling any pain, then only you can appreciate the cyst. Okay.
So we are good to go.
Yeah.
We'll slowly start with the incision.
Yeah. Sure.
So I'll just show the incision planning.
Yes.
Lesion is involved from 2-1 to 2-3, sir.
Yes. Okay.
So one tooth away from the cyst margin.
Yeah. Okay.
So slightly crossing the frenum.
Big 9. Okay.
So giving relieving incision there.
Okay.
And then involving 2-4, giving a wider base in relation to 2-4. That is the plan.
Yeah. If you have a marker, can you mark and show? If you have
Yes,
a marker,
yes.
yeah, it'll be easy for students to appreciate it.
Yes, sir. We just try to arrange the marker quickly.
Yeah, sure. So sir is planning to cross the midline in the center and give a vertical incision there and go along the clavicular region, and in 2-3 even again a vertical incision with the clavicular. Okay. Trapezoidal incisions. What are the theories of cyst? Theories of cyst. Two theories of cyst.
Looking like
Anyone? Mural growth theory, osmotic theory. இப்போ ஞாபகம் வருதா? This is the OPG of the patient. Okay.
கழுத்து கம்ஃபர்டபுளா இருக்குங்களா உங்களுக்கு? கழுத்து வலி இருக்கக்கூடாது.
This is a pre-op before doing RCT to the tooth. Okay. This is the initial OPG which is taken. You can appreciate the which up till the piriform aperture. That's the radiolucency there. I just want to show you. Okay.
Rajavan, so is just trying to mark the incision.
Sure. Yes.
Yes, marker.
Sir has gone along the frenum. Okay. Place incision along the frenum and clavicular incisions. Yeah.
Marker isn't great, sir. So I'll just try to.
So
It's.
Sir has started giving a release incision. Okay, on the right side. There's a single stroke. Okay, single stroke incision till their bone. Okay. Is going along clavicular around the tooth. Okay. Just giving a release incision on the posterior side. Okay. Between 2-3 and 2-4. Yeah.
Just redefining the incision, sir. Just going along the same incision once more.
Yeah. Always incision should be on the sound bone. Okay. So doing a mucoperiosteal flap reflection. Yeah. What periosteal we commonly use? Most number 9. Yeah. So it's trying to reflect the mucoperiosteal flap. Yeah. We can use a periosteal elevator or you can use a Howard's periosteal elevator also. Okay. For reflecting a mucoperiosteal flap. We need to be always gentle with the tissues, not to rush or not to do a rough job. Do gently reflect the mucoperiosteal flap from the bone. Okay.
That's line for irrigation.
What are the instruments sir is using to reflect the Austin's retractor? Very good. Sir is scoring the mucosa there. Okay. Separating the cystic lining from the surrounding mucosa. Okay. Sir is scoring it. Once you reach the cyst, you need to differentiate between the cyst and the mucosa, and you need to score so that you don't tear the cystic lining. Cystic lining will come down and the mucosa will go up, and then you reflect till you get a normal bone, and then he will place the retractor there. Okay, going irrigation so to see the clearly the site.
Sir, we have
Yeah.
reflected the flap now.
Okay.
The cyst has slightly come out through the home region, sir.
Oh, 2-1. Okay.
We can,
Okay.
zoom from it. Yes, sir. We can see that, sir.
Okay.
My periosteal elevator.
Yes.
The two region cyst has slightly come out.
Okay.
Now we have negotiated the flap and then taken out the thing.
Okay. Okay.
From that, wherever the bone is resolved, I will start removing the bone through that only, sir.
Okay.
And then access the cyst.
Okay. There's a thinning of bone.
Yes, sir. There is thinning of bone.
Yeah.
In one area, in relation to 2-1,
2-1.
the
Okay.
bone is completely lost there.
Lost. Okay.
If you can
You're
see
going
that.
through that. Okay. Yeah.
Yes, sir.
Can I appreciate that? There's a thinning of bone there. Okay. And in 2-1 region, there's exposure there of bone. So, sir, trying to go along with that.
If you see,
Yeah.
in 2-1, yes, sir. 2-1 is also mobile.
Mobile, yeah.
The tooth is mobile, very periodontally compromised.
Okay.
We'll try to see.
Yeah.
Select, sir.
Sir is using a round burr. Okay. Round burr with a straight hand base. He is creating a window on the anterior wall. Okay. Already it's a thin bone. You need to go very slowly. Remove the thin bone on the outer cortex. Okay. Till you get the firm bone. Okay. Till you get the firm bone, you need to remove the soft bone around the cystic wall. Okay. Over the anterior surface. Okay. Try not to damage the root tips when you're doing this. Okay. You need to be gentle as possible with the irrigation.
So we are trying to
Yeah.
locate the cyst.
Okay.
So plan is to remove the cyst, and also we'll do the apical portion of the root tip will be. We are planning to remove the
episiotomy. Yeah.
apical portion,
Okay.
sir.
Yeah. We can't able to see. Okay. Okay. Once you finish it, you can show us. Okay.
Sir, so I have just de-roofed the cyst.
Yeah.
Now going into the cyst cavity.
What sir is using to? What instruments are using to scrape the epithelial from the surrounding bone? What is that? The spoon shape. What is that? What curate? Name of the curate? Lucas curate. Have you heard of Lucas curate? It is a Lucas curate. It's like a spoon shape on both the sides. Okay. We need to use that, and you need to scrape the cystic lining from the surrounding bone. That is enucleation. Okay. You need to scrape the lesion cystic lining from the surrounding normal bone. Okay. You need to start from one side and then not to break the epithelium. If you break the epithelium, again, it will be very difficult to remove it off. You need to take in toto. Sometimes it will be very firmly attached on the inner surface of the tooth or the tooth root. That will be a difficult part to remove usually. Okay. Rest of things you can remove. Only the cystic lining, which is just under the root surface of 2 tooth or any tooth, is difficult to remove. Okay, so
Sure.
there'll be small amount of remnants will be there. So you need to be carefully and remove it off. What will happen if you leave the remnants or any small part and close it up? You have a high chance of recurrence. Yes. What's ours using instrument is it is a Mitchell's trimmer. Mitchell's trimmer. Okay. One side is sharp, another side is blunt. You can see the cystic lining moving once are scraping off. Yes. You see the cystic lining moving once he scrapes from the bone. Yeah. You need to remove as a whole. Okay. Try to remove always the cystic lining as a whole.
So slowly trying to
Yeah.
walk around the bone
Yeah.
to mobilize the cyst
Yes.
lining.
Palatally, it is eroded, no?
Yes, apparently it is involving the palatal
Yeah.
mucosa.
Okay.
You can see that some of the cyst lining is also going interdentally, slipping
Okay.
into the
Okay.
tooth spaces.
Okay. Yeah. 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 We can appreciate that. Once you all scrape from the surrounding bone, The tissue will be holding in the palatal surface. Okay, palatal mucosa. So you need to incise it from the palatal mucosa. You can't scrape there. Already a bone is not there in the palatal surface. Okay, only the mucosa and the cystic lining. You need to at last one once he scrapes from surrounding bone, the last to hold is in the palatal mucosa where you need to incise it from the palatal mucosa. Yeah.
Can you hold it? Yes. Can you hold it around?
Sir has asked the assistant to hold the what epithelial lining. Okay, so that it'll be easy for him to scrape it off. Okay. Lining. Yeah.
So medical legally, just a word of caution, that particular tooth was already mobile, correct? That has been noted and it has been written in the informed consent. Tomorrow, patient should not tell that after the surgery only the tooth became much more mobile. So while trimming that bone also, we should take caution that it doesn't make that particular mobile tooth much more mobile. So the patient should be informed about this, and in the consent form, before starting the case itself, it should be noted very well.
Thank you, sir. Thank you for the input. Always cystic cases will take time. Okay, it's not easy as of all the rest of biopsies what you do. Cystic enucleation will always take time because you need to be careful and remove all the epithelials of lining together. Okay, so I was trying to pack the gauze and scrape it around the bone for a tissue to come out. Okay, it'll be easy. Once you start scraping the cystic lining, what I usually do is on
Hold
one
it.
side I will start scraping off and
Hold it
I
around.
have a small gauze which is go inside and then tuck it inside and then if you tuck it more, the flap will come up. Okay. And it will be holding only to the palatal mucosa alone. Okay. Sarah's almost done. Yeah. The only holding part is on the palatal mucosa. Okay. Mainly. You can see the cystic lining which is holding. Yes. That is a cystic sac. So I was using a knife to incise it from the palatal mucosa. Okay. Because there's no bone in the palatal region, you can't scrape it. You can't scrape the lesion from the palatal side. So he's trying to incise the cystic lining from the palatal mucosa. Okay. Okay. Be careful not to tear the mucosa and put a hole in the palate. Yeah.
Okay. Najib, so we have
Yes.
just removed
Yeah.
the cyst lining
Yeah.
slowly
Nice.
from
Yes.
try to detach it from the nasal mucosa and also
Okay.
the parental mucosa.
Heart and mucosa.
Some
Okay.
small remnants are there, which I will try to curate and remove.
Okay.
So if you can see, once the cyst lining is removed, the bleeding, everything almost gets stopped.
Okay.
So then the cavity looks clear.
Yeah.
Okay. So for this perimeter cyst removal,
Yeah.
maybe if we have a laser unit,
Okay.
it is again helpful. So especially whenever the cyst is attached to the nasal mucosa,
Okay.
to the parietal mucosa, laser assisted surgery is that's better. It's more
Okay.
convenient for the patient as well.
Okay. Do
But,
you use any irrigations other than saline? You use a betadine or hydrogen peroxide or anything, James?
yes, yes, sir. Yes, sir. We can use betadine
Yeah.
for its antibiotic or antiseptic
Antiseptic
properties.
purpose. Yes.
The normal saline is sufficient, sir, most of the time.
Okay.
So for the benefit of the audience, if it's going to be the other types of biopsy, it is advisable that whenever that biopsy tissue is being taken, it has to be immediately
Then the formalin,
placed only in 10 percentage of formalin.
formalin solution.
It should not be washed with any other medicaments or hydrogen peroxide or any, because it will give false positive or false negative results.
So I'll try to, the nasal mucosa is clearly seen.
Okay. Yeah.
The cyst has perforated the nasal floor.
Okay.
I'll try to zoom it and show
Yeah.
that.
Yes. Can see the superior region. Okay. Even the nasal floor has been eroded and the palatal also eroded. Okay. You can appreciate that. So I will show you once. Okay.
Are you ready? I'll just zoom in this area towards the nose. So if you can see that section. So if you can see this area where the
Yes.
section tip
Yeah.
is,
Superiorly. Yeah.
yes, superiorly,
Yes.
there is a resorption of the nasal flow.
Okay.
I place the curate,
Yeah.
and then that's the nasal mucosa, which is
Okay. Yeah. Can appreciate it. Yeah.
slightly the breast.
Bleeding. Yes. Yes. You appreciate, guys. Yes.
Yes, sir. Here, exactly here,
Yeah.
going towards the nose.
Yeah. We can see James.
Yes, sir.
Yeah.
So now cyst is almost removed.
Okay.
We will try to locate the small remnants which are attached to the along the roots. I'll remove that
Okay.
small amount of granulation tissue which is around the tooth.
Okay.
And once it is done, we'll start with the episectomies. We'll
Okay.
remove the tips of the
Okay.
roots.
You're going to fill with anything? Or
No, so just going to remove the contents.
condensed? Okay.
They have overshooted the.
Okay.
So we just cut the
GP.
root tips.
Cut the root tips. Okay.
Surely.
Sir is trying to scrape the remaining remnants. Okay. So that it will be a
So now I'll try to further widen and expose the root tips of the canine and the lateral.
lateral. Okay.
Because the lateral root tip is slightly pallately tilted always.
Okay.
We need to remember that.
Now, using a round burr, be careful not to cut the roots. Okay. Be gentle. And only the superficial bone is removed to expose the root tips. Okay. So it's exposing the lateral root tip. It's trying to expose the canine root tip also. Okay. Lateral and canine root tips for episiotomy. Okay.
side திரும்பிக்கங்க. இந்த side திரும்பிக்கங்க. So now if you can see all the root tips are being exposed.
Yes.
I'll slowly start to cut the canine.
Okay.
Remove that.
Yeah. You use a round burr to remove the tips. Yeah.
Yes, sir. We can round burr or maybe a 701 burr,
One burr,
which is
yes,
much
yeah.
more thinner, is preferable.
Yes. Yeah. Sir is using a round burr to remove the tip. Usually we use the 701 burr, which is very thin. It is easy to cut. Okay. We hardly cut 2 to 3 mm, not beyond that. Okay. Generally, some people will give a retrograde filling with MTA, or we can use a GAC or something. Okay.
So I'm just trying to remove that tip of the canine.
Okay.
So canine has been removed.
Yeah.
Now I'll remove the laterals. The lateral, if you can see, the root tip is going towards the palatal aspect.
Yeah.
It's a 701 burr இருக்கா?
Sir is going
I
very
just
gently.
change over to 701, sir.
Okay. That will be better for, yeah. For lateral, which is already touching the canine.
Okay, ma.
Sir want to be
அப்புறம்
careful.
இருக்கீங்களா?
If we use a round burr,
Okay.
definitely we will touch the canine. Okay. So you
இருக்கா?
want to use a
மைக் ஒர்க் இருக்குதா?
701 burr. Okay.
முடிஞ்சிருச்சு அவ்வளோ. சரியா? Nacham sir, another thing is always when we are doing the procedure,
Yeah.
it is better to communicate with the patient,
always.
like
Yes.
how they are feeling, how comfortable they are.
Whether they have pain or not. Yeah.
Yes, always the communication with the patient helps them to build the trust, and also that they understand that we give utmost care for them.
Care for them. Okay. Yeah. Sir is using a 701 burr. Okay. To remove the root tip of lateral. Okay. 2. Sir has done that. Okay. Root tip of 2 is removed.
The two one is slightly tricky here, sir, because it's already mobile.
Okay.
I'll try to just negotiate that and then
Yeah.
try to save the tooth.
Grade 2 mobility.
Yes, sir, towards grade 2. Towards grade 2. Maybe if we can sacrifice the tooth, a very minimal amount of bone is supporting the tooth.
Okay. Since it's a young
Yes,
patient,
as you said, sir, always it's better to inform the patients regarding the complications, like we lose the tooth intraoperatively. It's better to inform the patients.
Yes.
Rather than having a sorry face later.
Yeah. Since it is a grade 2 mobility, it's a young patient, we need to try to save as much as possible. Always inform the patient. Later on, if it is very mobile or it's going to be mobile because patient is having a what habit? Trusting habit. Patient still continues. If we don't break the habit, if it still continues, definitely it will go from grade 1, 2 to grade 3 and we need to remove the tooth. Yeah.
And generally, in any maxillofacial surgery, always the principle is bone belongs to the patient and tooth or the pathology belongs to the surgeon. So every of bone is very important.
So I removed all the root tips.
Okay.
There's some amount
Okay.
of granulation tissue assist lining. I will just try to locate and then remove that.
Okay. You're going to pack anything in the empty space?
No, sir. No, we are not packing. There's some other options. Maybe we can put in some. If the cavity is relatively smaller, we can pack. We can place some platelet PRFs or things like that. Usually, bone graft is not preferred, sir.
Yeah.
Because the site is usually infected most of the time.
Okay.
So once the root tip of toe one is removed, we can send some amount of granulation tissue underneath the root surface.
Okay.
Just trying to
remove it off.
negotiate and remove it.
Yeah, bone graft is definitely not a choice because of infectious. We don't do that. Like to pack with the ab gel or anything to prevent the dead space there or anything?
Yes, sir. Sometimes if there is some undue bleed from the nasal mucosal side,
Okay.
we can place abgel. Sir. Otherwise, we do not place. But that empty space can be, if abgel is kept,
Okay.
that empty space will be free.
Free. Okay.
And also, it will be prudent to check the palatal side whenever we are removing from the palatal aspect.
Okay.
Whether there is creating any tear in the palatal aspect. Now it's all clear, sir. Not a problem.
Okay. Yeah. Pack with anything or
So can I lift it up slightly?
Anybody know what is PRF? What is PRP? What is PRF? Rich for plasma is PARP and rich fiber is a PRF. Okay. Usually, if you plan earlier, we should have done a removal of a 10 ml from the patient, do a centrifuge and get a PRF, and we can keep a PRF inside. It is has multiple growth factors and it will promote wound healing also faster. Yeah. So this removing the remnants from the palatal mucosa. Okay. Older days, they used to have a hydroxyapatite as a irrigation. Okay. They use saline, betadine, as well as some few drops of hydrogen peroxide. Previously, they used to irrigate it so that any remnants will get burned, so that recurrence is less. Nowadays, we don't use hydroxyapatite at all. Okay. Just saline, or I use saline with betadine. Okay, that is more than enough.
Okay. So I have almost completed it.
Okay.
Just packed it to wait for the bleeding to settle.
Okay. Yeah.
And then we can irrigate and then put the sutures.
Okay. Sutures, what suture? Your cervical or absorbent, non-absorbent?
Preferably for oral cavity, silk is sufficient, sir, because after a week we can remove it.
Okay.
We can use vicryl sutures.
Okay.
But one disadvantage is it takes longer time to get resolved.
Okay.
The patient finds it difficult after a period of 1 week to 10 days because it resolves maybe 3 weeks or sometimes even at the end, 4th week we can see the suture there.
Okay.
So it is Silk is better always, sir, for oral cavity.
Okay.
Sometimes the patient is not able to come back to us for the suture removal. They are
Okay.
traveling.
Yeah.
In that instance, definitely vicryl. But what we need to tell them is they have to maintain a good oral hygiene.
Hygiene. Okay.
Because vicryl tends to absorb the food particles and then water or everything, and then it swells up. So, and then it will be a source of infection as well.
Okay.
So, for good maintenance, we have to always tell the patient when we are using vicryl sutures.
Vicryl sutures. Okay. Yeah. As I said, vicryl suture will resolve. It will take 2 to 3 weeks to resolve. And we need silk suture is always better because after 1 week is not 1 week is more than enough for healing, not more than that. So, and in our Indian scenario, the people will not keep properly the oral hygiene. If any food particles which goes and stuck in, there will be a gaping or dehiscence or anything. So, better always to have a silk suture and then recall the patient after 1 week for suture removal. Yes.
The remnants, but we'll just keep it in the gauze and then show them. So we're just showing the cyst lining what was removed.
Okay.
Just and then we'll be submitting it for histopathological. Also, although the diagnosis is almost clear, it's a periapical cyst from a traumatic tooth.
Yeah.
Still, we'll subject the tissue for histological evaluation.
Okay. That's a saline you dropped, no?
Yes, sir. We are just rinse it with saline.
Okay.
Now immediately we'll transfer it to form plates.
Can you appreciate, guys, the cystic lining? Okay. With the 2, 3 root tips. Yeah. We usually send for histopathology for final diagnosis. Okay.
இதுதாம்மா சரிங்களா
Generally, as sir said, we take the tissue and we drop exactly into the formalin. Okay, 10%. Generally, okay, we don't keep it in saline and then keep it in formalin. Straight away, we take the tissue and put it in the formalin. Okay, that will preserve the cells. James, you are planning for simple interrupted suture or any other suture you like to?
Yes, sir. Since we have the relieving incisions, we'll put simple interrupted suture, sir.
Okay.
Since it's a clavicular, we go take bites from the upper side and go towards the palatal.
Okay.
Then come back and then suture it.
Yeah.
Yes.
Okay. So they put it in the formalin and send it for biopsy. Okay.
Such. Now we'll also check for any sharp the tooth ends what we have cut, sir. If it is not rounded,
Okay.
slowly, if you can see that once the packed it with gauze and then for sufficiently for 2 or 3 minutes.
Okay.
Almost the bleeding has completely settled.
Okay.
Now you can zoom in that area.
Yes. You can appreciate it. So I was trying to rounding off the root tips, which has already done. Okay, there's sharp margins in the root tips, which you want to smoothen it up before closure. Yeah. And some surgeons will also trim the edges around the cystic cavity so that any residual will come out and we'll have a good healthy bone. Okay, if it is a thin or soft bone, we need to trim around all the edges so that we have a good healthy bone. Okay.
Dr. Nachipan, what are the materials can be packed at the root tip? What is your school of thought regarding?
Some people have MTA, which is costly also, and generally we do is GIC, which is a type 9. Usually it's good. It's good, sir. Type 9.
Some people say that you just burnish the ends of the root tip with your ball burnisher. That itself is enough. And one more reason for recurrence is generally we curate all the entire cavity, but sometimes there are remnants distal to the root tip.
Yeah. That's what.
So that is the area of
That's the
interest.
area of interest. Yes.
Autograph. Sir, autograph. Switcher. 11. Huh? Yeah.
There's a vehicle suture, James.
Yes, sir. We are using the Vicryl.
Okay. Sir is using absorbable suture vehicle. Okay.
The chicken number.
Generally, you close the release incision first, and then you go for a clavicular. Yeah.
Yes, sir. Yes,
Yeah.
sir. And try to secure that frenum into
Yeah.
that exact
Yeah.
location.
Okay. So I was trying to first give the suture along the clavicles, okay, along the lacy incision, so that you need to secure the frenum in the anterior region, okay?
ಆಯ್ತು ನಮ್ಮ ಹಾ
He has taken one bite in the label and one bite in the palatal, okay? He's taking the palatal surface, okay?
ಆಯ್ತರಂದ್ರೆ ಹಾ
Sir has given a simple interrupter suture, yeah? And securing the frenum, the frenal attachment there, okay? Since it's already a diastema or yeah, the space is easy to put. If the tooth is very intact, it's very difficult. You need to pass through and get it. Again, you need to pass via, okay? It'll be like a vertical matter suture sometimes, okay? So I was trying to secure the lens incision on the posterior side. Once you do that, it'll be stable. Then you can do a clavicular incision quite easily. Okay. Yes, passing through the palatal surface. Okay, getting it out. So I was taking a bite again from the palatal side and going from palatal to labial. Yeah, can appreciate that.
வலிக்குதாம்மா? She has some pain in the palatal side, sir,
Okay.
especially in femoral region.
Yeah.
Otherwise, we can go around the tooth.
Okay.
Then,
You're going around the tooth. Okay.
yes, going around the tooth.
So I was going around the tooth.
And then anchoring the suture
Okay.
to the tooth, sir.
Okay. Can appreciate that. Yes.
So for beginners, initially whenever we are going to make very broad incision and then we are going to suture, so we cannot just start suturing everywhere. So initially we put a stay suture and then check whether the flap is approximating. And in most of the surgeries, this suturing should be meticulous. So you give a good watertight closure in that area so that food or other particles will not invade the surgical site and will not get secondarily infected.
So now I'm securing the relieving suture.
Relieving suture on the posterior side. Yeah. You can appreciate the gingival papilla between 2-3 and 2-4, which is intact. Yes. Once he has given the suture, now the papilla is intact, like before. Okay.
Sutures relieving. So now suturing the anterior release.
Okay. Okay. It's just an approximation. Don't over tight it. What will happen if you over tight it? If you put a full strength and do it, what will happen? Any compromises? Compromise will be on the blood supply. Okay. So you need to approximate the tissue, not to over tight it. Okay.
So now you can see that almost the papilla are coming and resting on
Yes.
the
Yes. We can appreciate it. Yes.
passively. Juice or huh? She can have some juice immediately. அவ்வளவுதாம்மா?
Can appreciate the gingival papilla nicely attached, okay, to the clavicular surface. Okay. Still one more suture to go.
Yes, last one.
This is the last suture. Okay, sir is completing suturing. Okay.
So once suturing is done, all the bleeding has completely stopped.
Okay.
Irrigating, trying to remove all the blood clots which is there
Okay.
in the patient's mouth, and then give him neat surgical wound.
Okay.
So the idea is like after the surgery, it should always be like as though we have not done anything.
Anything.
That is how we have to see surgery as such.
Yeah.
Surgery as a heart. Because sometimes even when during my initial days or even now, I always tell it is like an art. We have to perform it like an art,
Art.
and then upgrade ourselves every day to slowly master the techniques of surgery, and then give the best of care. What is best possible by you, you should deliver that to the patient. So they'll be ultimately benefited from the treatment outcome.
Sure, James.
At the end of the surgery, if the patient is having some pain, we can also put in some local anesthetic, make them comfortable immediately.
Okay.
So that is also another option which we can do. Otherwise, immediately after surgery, now dispersible painkillers are available. So
Okay.
ask them to mix them 1 or 2 tablets according to the dosages, and then give a desired dosage as a dispersible tablet.
Okay. Do you give any pressure dressing extraorally for this? No.
No, sir. No, sir.
No. Okay.
No, I didn't have any obvious bleeding. So
Okay.
I'm not planning for any pressure dressing.
Okay.
Post-operatively, so sometimes we can give a small dose of steroid because of
Okay.
the manipulation of the tissue and the periosteum underneath. Since in the maxillary side, there is a lot of free tissue space. So inflammation can happen within the lip. It can extend even up till the infraorbital rim.
Okay.
Sometimes we can also give intramucosal dexamethasone, sir, to
Okay.
reduce the inflammation. Otherwise, a small dose of steroid, maybe prednisolone 10 milligram BD dose for 1 or 2 days.
Okay.
And then all more important is we will advise the patient to give good amount of ice compression post-operatively, sir.
Okay.
Because that will definitely help to reduce the swelling
Swelling.
and also the pain factor because of
Okay.
yes.
Yeah, can appreciate it. Yes.
Yes, sir.
Thanks, James.
Thank you, sir. Thank you.
Thank you. Thank you very much.
Thank you, sir.
Any doubts? It's make me feel like classroom. எப்பவும் கேட்பேன். எனி டவுட்ஸ் சத்தமே வராது. either you fully understood or not understood. Okay. Thank you, guys. Thank you.
Thank you, sir. Thank you. Mike.
Thank you, sir, for this insightful session on biopsy. Now, let us break for tea and snacks. We'll meet again for another session on biopsy. We have an excisional biopsy on the case of mucocele. So I hope you will come refreshed and recharged for that case as well. So we can have our tea and refreshments outside the auditorium. I request the participants to collect the refreshments. Thank you.
in the lower lip of 1 to 1 centimeter in the lower labial mucosa in relation to 3 2 and 3 3. Yes, you can appreciate that of size 1 to 1 centimeter hardly approximately. The swelling is soft in consistency, non-fluctuant in nature and attached to the underlying mucosa. What will be your diagnosis, differential diagnosis?
Check.
Anyone? Differential diagnosis. Patient has a habit of lip biting and patient has swelling for the past 2 months. Yes? Lipoma, fibroma. Okay. Can be a traumatic fibroma. More common in the lower lip. Yes. Stress ulcer. Is ulcer more related? Ulcer is different. It's a swelling. It's not an ulcer. Anybody think of other than fibroma? What is it? Yes. Ranula. It is a firm nodule, smooth nodule, which is present in the lower lip. What's the common, other than fibroma, what is the other common thing we can expect? Any trauma to a minor oral surgery gland is a mucocele. Yes. That's like, uh, yeah. Yes. So provisional diagnosis will be mucocele in relation to the lower labial mucosa. The differential diagnosis will be fibroma, hemangioma, lymphoma, your minor salivary gland abscess, mucus retention cyst. இதுக்கு அதுக்கு என்ன டிஃபரன்ஸ் இருக்கும் basically? Yeah, fibroma is a benign fibrous tumor which is occurring due to trauma, okay, due to injury. Your lipoma is again a fatty tissue which is a extension of fatty tissue, benign, okay. Your mucocele is a what? Any damage to the minor salivary glands will have a leakage of secretions around the tissue and it gets pulled up and it gets enlarged. Yes, that is mucocele, which is more common in the lower lip. Yes. And it's a case of mucocele, okay. Patient has a habit of lip biting, so due to injury to the minor salivary glands, and it is a mucocele and plan for excision biopsy and send for biopsy. Yes. Yes, they will start. How will you put the incision for a excision biopsy for mucocele? You have a mucocele, you are seeing the picture, okay. How will you go about putting the incision? Once you infiltrate with the insulin syringe, everything is done. You want to excise now. How will you go about? Yes, you have a mucosa. Below the mucosa, we have a mucocele. You go on top of the mucosa, or you don't touch the mucosa, you go around it.
I don't know. You can just hold it
Yes, for excision biopsy.
like this. Section கூட வச்சிடலாம். We just
Yes.
mop it.
என்னடா? Yes, we need to include the pathology as well as the normal tissue. You go around and give a elliptical incision around the mucosa. Go to the depth and get the mucosa as a whole, not to puncture the mucosa. If you puncture the mucosa, there will be again a seepage of the salivary gland into the normal tissue. So try not to puncture the mucosal take as a whole. It is like a bag, take as a whole, along with the surrounding normal tissue. We generally put a elliptical incision around it and remove it in total. Yeah.
So for this mucoseals in olden days, they used some alginate technique. Have you ever heard about that? Any idea? So in olden days, what they did is they just inserted a small needle and then small amount of fluid from the mucosal they have aspirated, and a liquid mix of alginate has been injected into that, and then that becomes solidified so that they can remove the entire mucosal in toto. But nowadays it is not been practiced.
It's new to me, sir. Thank you. So always be careful when biting your lips or others' lips. Okay, don't cause injury. Okay, even a lip sucking can cause injury. Okay, even lip sucking, lip biting, or any sharp like bony spicules or a fish sharp thing, anything which is poking the lips will cause mucosal. Okay.
Yeah, focus for treatment.
Yes, sir is going to give an infiltration. Okay.
So I already gave some amount of mental nerve block.
Okay, mental block. Okay.
Now just infiltrating around the.
Yeah. Why sir has given mental nerve block is the region is between 2-3 and 2-4. So sir has given a mental nerve block and is giving infiltration around the mucosa. Yeah.
Because the direct injection into the lip will be more painful, sir.
Yeah. Yes.
So
Yes.
I've given a mental nerve block and then
Okay. Yeah. Sir is going around the mucosa, not under the mucosa. You should not damage the pathology. So he's going around the mucosa and giving infiltrations. Okay. If the color of the mucosa, if the color of the mucosa is bluish, we can think of hemangioma. Okay. Hemangioma is damage to the blood capillaries. Okay. So if it is a bluish color, you can think of hemangioma. Okay.
மருத்துவமனைங்க வழி எதுவும் இருக்குங்களா? வணக்கம். Sir, now
Yeah.
this is started to work.
Okay.
Slowly we'll. So as you said, there is two ways of doing that. Like doing a elliptical around the thing.
Okay.
What I thought is like I'll slightly make a vertical incision over the
Okay. Over the mucosa. Okay.
try to negotiate it, sir.
Okay.
I understand it is the mucosa is completely thinned out
Okay.
one area. So we'll try to slowly manipulate it, sir.
Okay. So sir is planning to go the do the incision over the over the mucosa. Okay. Around the mucosa. Okay. Over the
Very
need to dissect the overlying mucosa from the mucosa. That's what sir is doing. You should be very careful. You can easily puncture and your content will come out. Okay. Since it's very thin, you need to be very careful when doing this. It is technique sensitive. This technique is technique sensitive. Okay. It's not easy. Need to know how much depth you are going and where to stop. Okay. Your mucosa is hardly 1 to 2 mm thickness. That's it. You just give a overline incision and then try to disrupt the mucosa from the surrounding mucosal. Okay. If you put a electrical incision and remove, it is hardly 5 minutes to do this, 5-10 minutes to do this. But if you go this way, it will be tough. It will take some time. You need to be patient and do it. Okay.
So you can slowly see that
Yeah.
slightly coming out.
Yes. Your mucosal is coming out. Yes. Can appreciate it. Yeah. So let's give the mucosal incision and we are separating the mucosa from the mucosal. Okay. The tricky part is here is you need to remove from the base. Okay. That will be the tricky part here.
Mop, please. Mop.
While mop it very gently. Don't do vigorously and squeeze the mucosa and the content will come out. Okay. Always be gentle in soft tissues.
Just trying to put in the scissors thing.
Yeah.
It's a very small one. We will try not to break it.
Okay. So inserting the mucosa. Okay. From the underlying mucosal.
Yes.
And appreciate the thickness of the mucosa, which is very thin there. Okay. You need to release from all around. Okay. You need to release the mucosa from all around the mucosal so that the mucosal will come in total. Okay. At last, you remove from the base of the this one.
Now it's slightly try to hold on to the chip.
Okay.
It's completely coming out slowly.
Okay.
I try to hold it, then dissect it to the base.
Okay. So Sarah's removed all around. Now he's trying to remove the mucosid from the base. Okay. He's putting incision there and remove it into.
Mop this.
He's holding it very gently so that it doesn't break. Okay. Yes, sir. Stay suture. அதுவும் போடலாம் சார். That can also be done. Stay sutures can also be done. Sir is holding it with the AdSense non-tooth forceps, okay? He's using a AdSense non-tooth forceps to hold the mucosil, okay? He's almost done.
Yes.
And you can appreciate small minor salivary glands there. Once he zooms it, you can see.
So we can also try to do the small berry picking,
Okay.
and whatever is seen, we can also remove those minor glands,
Minor glands, okay.
and then give a clear base.
So moving a small minor glands around the mucosa, okay, to be safe. But again, once you do this, again, if the patient has the same habit of having a lip biting, again, there will be a recurrence. Okay. Unless you stop the habit, it's very difficult also to not to get again. Okay. Recurrence will come again and patient has to stop the habit of lip biting. Okay.
Okay, sir. It's almost done, sir. Now
Okay.
just will put some sutures.
Okay.
Close.
The fragile mucosa, you will try to remove it off or you put the suture over that?
Just the suture over that, sir.
Over it. Okay. Okay.
Yes. So I'll just show the mucosil, whatever was removed.
Okay.
It's a small one.
Yeah.
Just like a just in small minor salivary glands.
Okay.
Was seen in the base. Once the base is clear, we are just because if we start keep to pull, we will remove more the glands.
Okay.
Once the base is clear, so luckily we have got the mucosil in.
Yeah, that's excellent.
Yes, sir. Yes. And then we
All can appreciate this. Yeah.
Okay, so now we'll just irrigate the wounds and then put some sutures. Again, we are subjecting this mucosil again for biopsy.
Biopsy. Okay.
Yeah, it's a section.
Always send for biopsy for final diagnosis. Okay. You're planning to put vical sutures?
Yes, vical. Otherwise, even simple silk is also fine, sir. But 1 or 2 stitches.
Okay.
Yeah, we'll put the vical stitch. Vical stitch is available.
Okay.
So
Yeah.
the vical stitch. So, and then while suturing, what we need to remember is all this incision should follow the orbicularis or its muscle plane. So it is better in that way.
Okay.
And then when we're putting the suture also, we should not pull the lip so much inside.
Inside, yeah.
Because the dry and the lip vermilion should not get pulled inside. I'll just try to demonstrate that. This is a very small lesion, so we need not worry about it. For lesions which are slightly more close to the wet and the dry vermilion, we should not tend to pull the lip inside because that might lead to some cosmetic defect. So especially here it is there. Here it's slightly inside and it's a small lesion, no problem.
Okay.
Because sometimes if you take a bite and then pull it,
Yeah.
can you just, what happens is the lip margin will get turned inside. So that we need to be careful that dry and the wet vermilion will not get altered.
Oh, yeah. Understood what I said? Yes. If it is over the vermilion or on the junction of the wet and dry, we should be careful not to pull too much, otherwise it get everted. Okay, and there'll be a deficiency there. Okay, not always. Whenever you're suturing, try to suture as close as possible, as gentle as possible, not to pull the tissue and close it. Okay, just approximate, not to pull. Yeah.
You can see that the base is clear
Yeah.
almost.
Yes. Only just a mucosal bite. Okay, he's taking only just a mucosal bite, not too deep.
Yes.
Yeah. If he goes deep, he will be involving the spinal salivary glands again. So only the mucosal bite he's taking and he's closing it up. Yeah. Always check for approximation before you put a knot. When you try to suture, since his experience doesn't reflect the mucosa, once you start doing it, you uh, take a AdSense non-tooth, reflect the mucosa, and then take a bite from that. Not a single-handed bite. Single-handed bite is very tough. You need to experience it. You need to always hold the mucosa in the AdSense non-tooth forceps, reflect it, and then put the bite. Okay. So last suture. Even if it is a vehicle suture, try to call the patient after 1 week, see it is healed. Once it's healed, you can do a suture removal. Don't wait for the vehicle to get absorbed. It will take 2 to 3 weeks and it will be irritating for the patient also since it's a lip. He can't able to eat properly or chew properly because the thread will be irritating. So any suture will be at least for 1 week and then after 1 week you can remove it off. Yeah. Yeah, yes, done the closure. Yes. Yes. This is the closure, yeah?
Yes, sir. Yes.
Yeah. Nice work,
Yes.
James.
Thank you, sir. Thank you.
Thank you.
முழுங்கிக்கலாம் முழுங்கிக்கலாம். Okay.
Thank you, sir. Is there any questions? We have our experts here, so undergraduates and postgraduates kindly utilize this opportunity. About insertion, can you explain it? Because is there any calculation that it should be done in the middle of the mucosa seal like that?
See, sir, what sir has done is not exactly at the middle. He has done 3/4 from there. Okay. We can be either you can put the incision over the mucosa, over the mucosal, over the mucosa, over the mucosal, or as I said, we can go elliptically, prevent the mucosal incision, and then we can remove it off. Okay. If you're going around the elliptical and remove it off, you're taking along with the mucosa. It's quite easy. But this is technique sensitive. It is a good technique. It's a technique sensitive where we need to exactly because over the mucosa, the mucosa is very thin. Okay, you need to be careful in incising and in putting an incision over the mucosa. Okay, to be you need to get experience so that you should not. Usually, unexperienced person will try to go so deep so that you will puncture the mucosa. So over the mucosal incision is good, but you need to be experienced. So we can go either way, go over the mucosa or go around the mucosa, put elliptical incision, remove it off. Yeah. So that's more specification. Any other questions? Yeah.
Sir, is it always required to remove the mucosal in toto and to remove the minor salivary gland from the place? Will it
It's
contribute
a
in
small one, yes, we can. If it's a larger one, like more than 1.52 centimeters, this procedure is good. We can put over the mucosal, we can reflect the mucosa, and then we can remove the only the mucosal alone and preserve the mucosa over it. Since it's a small lesion, we can put a elliptical one, we can remove it off. If it's a larger lesion, we can save the mucosa, we can prevent the mucosa. Yes. Thank you. So, what she's asking is why you didn't pack the cystic content once you remove the cyst in the first case. Since it's a small cyst, we can pack it. Hi, James. We can pack it off. I love James to ask. James, that's a question that they need a question. Why you didn't pack the cystic content? Once you remove the cyst, the cystic space is there. Why you didn't pack anything? If you need to pack it because you need to prevent dead space. Now you didn't pack, you have closed it as such. Still, there's a dead space there. Is there anything to do with it?
See, it's a very small space, so you need not worry about it. It will eventually heal. Sometimes the cyst is very large, okay, and then what happens is if the palatal mucosa does not have a sufficient support, in the sense more amount of palatal bone is resorbed, then the palatal side you will have a defect. Okay, so if you leave it as such, the blood clot what forms, what happens is it tends, because of the gravity, it tends to push the palatal mucosa down. In those instances, what we will advise is sometimes we will take a preoperative impression. We can have an acrylic plate, okay, for the patient and then put it. Otherwise, even a soft splint is okay for the first 1 or 2 days. Okay, so till the blood clot which pushes the palatal mucosa down. If there is a stent, it will hold onto it. And as I told you, this was a very small case. Otherwise, you can also have an abgel which you can put it inside. Otherwise, even PRF you can pack it. Bone graft necessarily you can avoid it because this is an infection site. So although you can curate it, sometimes you can also use laser. Okay, bust all the infections down. But still, in an infected site, packing bone graft you should be avoiding. Okay, and then eventually all these small spaces it fills up with the blood. It gets filled up and slowly it gets converted into bone. So you need not worry about not packing that area.
Thank you, James. Any other doubts? Thank you.
Thank you, sir, for this insightful session. I think our undergraduates will be well versed with the topic of biopsy with today's discussion, I think. So, a big round of applause for our presenter and moderator. Thank you. Now, I request Dr. J. Naveen Kumar, sir, Head of the Department, Shri Ramachandra Dental College, to felicitate our moderator, Dr. Nachiappan, sir. Like, thank you, sir. Now, I request our HOD, Dr. R. Ria, sir, to felicitate Dr. James Bhagat, sir. Thank you, sir. Now, let us dive into the next interesting part of this today's program, that is the live surgical demonstration of implant placement. So, this session will be taken over in the operating room by Dr. Nikhil O. Govindan, sir, Director, Smile Train, Calicut. He is associated with Star Care Hospitals, Calicut. He has performed over 400 cleft repair and 200 plus orthognathic cases. He is very much skilled in corrective jaw surgeries for functional and aesthetic improvements. And as an expert in cleft lip and palate repair, we now are here to see his surgical excellence. To moderate this session, we have our very own Dr. J. Naveen Kumar, sir, Head of the Department, Sri Ramachandra Dental College and Hospital, with 20 years of experience. He specializes in managing craniofacial anomalies and cleft lip and palate repair, delivering transforming outcomes for the patients. He's actively involved in teaching and mentoring the young surgeons. We welcome you, sir, on the dais for moderating this session. So let's give a round of applause for the moderator as well as the operating surgeon.
Check, check, check. No, the forward. Forward. Sorry. Good morning, all of you. Can you hear me in the last row? Okay. Are you all awake? Most of you are undergraduates, no? Okay, class. So first of all, thank you, team Tagore, headed by the organizing chairman, Dr. Riaz, who kindly dragged me out of my college and brought me here for the session. Very much, I'm happy to come, anyways. So I feel this is a new experience for me in moderating sessions for implantology for undergraduates. It's a very nice experience. I'm trying to tone down this lecture, this moderation, so that we will try to inspire most of you to pursue implantology as a specialty. In my opinion, implantology as a specialty is unique in certain ways. Not the money, not that. And that apart, in my opinion, it is unique in the sense, yeah, somehow I feel it's not a degree based. It's more of a training based and specialty based. See, it's so surprising to see many of the top notch implantologists in the world are neither oral surgeons, nor prosthodontists, nor periodontists. They're actually implantologists. So I think we should have a degree called MDS implantology. It's more of a comprehensive specialty. So somehow, why I'm telling you this is because I shouldn't assume that it's an oral surgeon specialty. That's why it's appearing in oral surgery conference. Not like that. It is open to all. But training, and a lot of common sense is the key. So I was just talking to one of my assistants as I came